Hi everyone. Hi, I'm so excited to be here. This is such an amazing event. And Candy and Brad have done such a great job year after year, so I'm excited to be a part of it this year. So I am a clinical faculty at UCLA Medical Center in the Department of Child Neurology. I run an Autism and Epilepsy clinic in Santa Monica, UCLA. I'm also the founder and medical director of Pediatric Minds Medical Center in the South Bay, where we provide intensive day treatment services to kids with neurodevelopmental disorders and autism. And we also run a very small but awesome and amazing ABA program. Anyway, so today I was asked to talk about the relationship between autism and epilepsy and what we know about it. I'm going to briefly just touch on the definition of autism and epilepsy separately. We're going to go over the coexistence of both being common and why, and discuss how they have shared common biological bases and what this means for future practice and future treatment. So we know that autism is a neurodevelopmental disorder that has many different reasons or etiologies. Autism is a behavioral or phenotypic diagnosis, right? And the diagnosis is given based on a deficit in social affect or communication and the presence of restricted interest and repetitive behaviors. Usually the symptoms of autism start very early in life, definitely before the age of 3, and the current prevalence is about 1 in 68, about 1.4% of the population. And there's a ton of medical and psychiatric comorbidities, epilepsy being one of them. Autism genetics has really grown over the last 10-20 years. We have discovered a myriad of genes and gene loci that play a part in the autism phenotype or characteristic of autism. We've gotten good data from identical twin studies, monozygotic twins, where the concordance rate is about 70 to 80%. So we know that it's highly genetic. I mean, everything's in our genes, right? Some parts of it. We have now started to look at autism in terms of 2 categories of autism, 2 types of autism. One being idiopathic or non-syndromic, basically meaning we don't really know why. And the second category being syndromic or symptomatic, and that's about 20 to 25% of the cases. And a lot of that are either single gene mutations or known syndromes like Fragile X, and the rest of it is combination of various gene mutations that we've gotten to know. And perhaps the thinking is in the syndromic or the known category for the reasons of autism, perhaps it's best to describe that as neurodevelopmental disorders with autism characteristics rather than true autism is the way we think of it. So the idiopathic type of autism, the category that's about 75 to 80% of autism that we really don't know the cause of, we're definitely growing to understand that it's a combination of genetics and environmental factors. We know that it's multigenic, meaning that a combination of different genes have come together and with some sort of environmental influence, it kind of gives rise to the autism characteristics. So it's polygenic and environmentally influenced. And the difference occurs at the gene expression level. And what I mean by environmental factors, really we're talking about either prenatal factors like in utero exposure to drugs or alcohol or medications with side effects like Depakote, or perinatal events where there's birth trauma or stroke or low oxygen flow at delivery, or postnatal events where there is an infection or meningitis after the child is born. And so it's really important to realize that perhaps each one of those genes that are implicated by themselves may not directly cause autism or give rise to autism, but the combination of them in that individual together with an environmental factor is what brings on the autism characteristic. So now shifting over to epilepsy and describing epilepsy. So we know that the definition of epilepsy is when you have 2 or more clinical seizures in your life The frequency of epilepsy in the general population is about 1%. And now we have sort of revised the way we classify epilepsies, and we think of them all as being symptomatic of something or caused by something. Before, we used to say idiopathic, we don't know what's causing it. So hopefully eventually we're going to get there with autism as well. And so there's 6 underlying causes or categories for epilepsy. One is genetic based, when you have a gene mutation for certain types of epilepsies. Structural reasons, if you have a brain tumor or a cortical malformation. Metabolic reasons, if you have low blood sugar or any other metabolic disorder. Immune issues like lupus, autoimmune disorders. Infectious issues like meningitis, encephalitis, and of course a category that's known as unknown. We always have to have an unknown category where we just can't figure it out. And then the International League of Epilepsy made changes in the way they're describing epilepsy or classifying epilepsy as of last year, and so they sort of changed it to be done through a level system. Level 1 is based on seizure type, if you have focal or generalized seizures. Level 2 is seizure type based on the epilepsy. So if you have a generalized seizure manifesting with a staring spell, that's absence epilepsy. Level 3 is a syndrome based on syndrome. Certain epilepsy types occur certain age of life, so like absence epilepsy of childhood. And level 4 is when it's associated with something else like a tumor or stroke or tubers, like in tuberous sclerosis. So we know that there's a strong relationship between autism and epilepsy, and that's been recognized for a very long time. 24 to 40% of patients who have autism have either epilepsy or have abnormal EEG findings. And of that 25 to 40%, at least 25% actually have clinical seizures or meet the definition of epilepsy. There tends to be a bimodal peak when seizures present in the autism population once it's in early childhood, between the age of 3 and 5, and the second peak is in adolescence. There was a few studies looking at potentially there being a third peak in early adulthood, but that really hasn't panned out, and other studies haven't supported it yet. And so this sort of implies that there's the shared genetic risk of the two happening together. And so perhaps there is underlying mechanism that influences both, and that perhaps something in the environment is triggering it. So autism in epilepsy. So the lifetime risk of having a diagnosis of autism in the epilepsy population is about 6%, which is higher than in the general population of autism in the general population, which is about 1.4%. And it's probably even higher than that if you look at younger populations, if you look at patients who have other known syndromes. There was actually a population-based study out of Finland, and this is just looking at Finnish population. They looked at 4,700 kids born between 1987 and 2005, and they found that at some point, patients with epilepsy, about 54% of them later actually received a diagnosis of autism. So it's probably higher than just 6.3%. And so perhaps epilepsy may contribute, or maybe in some cases even cause, certain developmental impairments predisposing you to the autism phenotype or characteristic. So epilepsy in autism, we know that there's a much higher risk of having epilepsy in the autism population if you have comorbid intellectual disability. There's also been relationships that are higher if there's that make it a higher chance of occurring if you have a family history of epilepsy, if you have a syndromic or a known gene mutation for the epilepsy, perhaps if you have more severe form of autism, which is, again, depends on what study you look at and how they define the severity of autism, because usually when they say severe autism, they imply intellectual disability, so that might just be one and the same. And if there's a history of developmental regression, and there's been some studies who also show that being a female gender increases your risk of having epilepsy and autism. So for sure, out of all of these, intellectual disability, the existence of intellectual disability in the autism population increases your risk the most of having epilepsy, 3 to 5 times the norm. So prevalence of epilepsy in patients with autism and intellectual disability is about 22% versus about 8% in autism without intellectual disability. And another interesting study looked at not only is there a higher risk of having epilepsy for the patient with autism, but even their family members. So families who've had multiple kids with autism, or they're referred to as multiplex families, tend to have an epilepsy prevalence within the kids of about 13% versus 2% in families who only have one kid with autism. So there's definitely genetics at play here. So then we have this entity of not just seizures or epilepsy, but abnormal EEG findings, and this has been a mystery. And we know that there's a much higher prevalence of abnormal EEG findings in the autism population compared to the general population, about 20 to 38% versus about 1 to 5%. What these abnormal EEG findings mean in general, not just in the autism population, we don't truly know or understand, but we're just learning about them, and we can only look at correlations and other disorders that have had these findings. We know that potentially there's an increased risk in future development of actual seizures. So you might do an EEG and you see abnormal discharges. Are you going to do anything about it? Or at least the minimum you can do is kind of monitor your child to make sure that seizures don't develop when they're older, because they are at an increased risk because of the discharges that are seen. And do the discharges, the presence of the discharges themselves actually increase the risk of having autism? Well, there's a couple of disorders we're going to review real quick that the EEG discharges have been associated with the autism phenotype or characteristic. And we do know, and there's been correlation with these EEG discharges impacting learning. If the discharges are occurring in critical periods of learning during your development, and depending on where they're occurring, they can definitely disrupt memory and disrupt performance. And just a few examples of the disorders that have been associated with these abnormal discharges without actual seizures and autism. One is Landau-Kleffner syndrome. Have any of you heard of that? So this is something that occurs around the age of 3 to 4. Child usually has normal development, and the first presentation is with language regression or loss of language. Again, these kids were very, very normal to begin with, and the onset was after the age of 3 to 4, not before 3. And the reason that's critical is because after the age of 3 or 4 is where the speech centers sort of get differentiated and fixed in place in our brain. And so the language is there, and then they lose it, versus before the age of 3, where the language hasn't fully developed yet. It's sort of all over the place. So that's a big distinction between that and the regression that we sometimes see in autism. And so these kids are normal. They have regression after the age of 4 usually. And the first way they present is they go silent. They just stop talking, and then they seem more autistic. And when you do their EEG, their brain is just discharging away. Their body's not doing anything, but their brains are just firing away. The other entity that's sort of related to Landau-Kleffner syndrome is ESES, which is referred to as electrographic status epilepticus of sleep, or continuous spike wave discharges. And again, this presents similarly, maybe not as dramatically, and it's not always 3 to 4, it could be even earlier than regression, where there's communication deficits, memory impairments, behavioral issues may or may not be associated with autism characteristics. So this is something, if you catch and treat, you can actually improve and fix. About a third of cases actually return back to baseline. The other cases, they definitely recover, but they may not regain all of their cognitive functioning. So why is there this autism and epilepsy co-occurrence? And just to sort of put it in a very basic way to understand, more and more studies have shown through functional MRIs and EEGs that maybe autism, or there's a lot of data supporting this now, is a function of underconnectivity and overconnectivity in certain parts of the brain. So there's overconnectivity within the temporal lobe and underconnectivity between the frontal and temporal lobe. And in epilepsy, the thinking is that there's an imbalance in excitatory and inhibitory factors in certain parts of the brain, right, with glutamate and GABA, and then that this may further drive the connectivity issues. to contribute to it. And getting a little bit more scientific about it, we know that when you have seizures in your brain, repeated seizures, this causes physiological and functional deficits in various parts of the brain that are very prone to seizures, like in your hippocampus. This impacts your organization between the synapses of your brain cells, and it impacts the interneuron connections between each of the brain cells and impacts the organization of the brain globally. Eventually, this leads to impairment of the plasticity of the brain and imbalances of excitatory and inhibitory neurotransmitters. And in general, it just causes a disruption to the cortical networks of the brain. And these cortical networks are often necessary to acquire very important, vital developmental skills in your early life development. And that this is why it gives rise to the autism phenotype. So that's the relationship. So it's complex, but it makes sense that both could be at play. So just a couple of questions. So do the presence of seizures cause or worsen autism? And the second question is, does seizure burden, meaning frequency, how often you have seizures, impact autism and the severity of autism? So impact of epilepsy on autism. So the data in this really comes from the early life epileptic encephalopathy, so seizures that occur early on in life. So we know that early life seizures are associated with very, very severe developmental deterioration and loss of skills. And specifically, it impacts, again, the hippocampus, the synaptic organization, disrupts the metabolism, not only of that area that the seizures occurred in, but also in the areas that are connected to it through the interneuron connections, and this gives rise to global dysfunction of the brain. And infants are highly susceptible to this because their brain is so young and still developing and maturing, and that's why it's so impactful and detrimental when it happens early in life, in the first 2 years of life. And so there's also there's a thought going on that, well, is this what's perhaps underlying the regression that we see in a subtype of autism, right? About 30% of cases with autism, parents say, my kid maybe was a little delayed, but they were engaging, they had eye contact, and then around the age of 18 months, they seemed to lose those skills. And so the thinking are they part of the subset of kids that eventually are going to have epilepsy and they have these abnormal EEG findings? The problem is, us as neurologists, we don't see those kiddos right when they're regressing, and so we can't evaluate them, and we don't have enough data to look at that. They always get to us after the regression has occurred, and by then sometimes the EEG findings go away because these abnormal EEG findings and seizures, they kind of come and go. And so with the epileptic encephalopathies, specifically like with West syndrome that's associated with infantile spasms, hypsarrhythmia, which is an EEG finding, and developmental regression, we know that there is definitely a high association with the developmental regression eventually leading to autism findings. Specifically in one type of epileptic encephalopathy, the tuberosclerosis complex, the association of autism in that population is about 64%. And Dravet syndrome is another infantile epileptic encephalopathy that presents with loss of skills, behavioral issues, developmental regression in the autism phenotype, and about 73 to 75% of those kids eventually have a diagnosis of autism. So yes, definitely early, at least in early life, when there's a lot of seizures, you can say that it can give rise or exacerbate the development of autism, but it's thought that autism is a consequence of the neurodevelopmental regression and not as the main primary dysfunction. So there's enough developmental deterioration and loss that it leads to autism. Now, this doesn't mean that older kids, when they have seizures, a lot of seizures, does this happen or not? It just hasn't been studied enough yet can this happen in 4 and 5-year-olds? We just haven't studied it yet. So treatment recommendations, yes, you should absolutely treat and stabilize the seizures because we know seizure control is critical in controlling for development, to preserve development and maximize developmental functioning. And eventually it might even lessen the burden of autism or the autism features. What about the frequency of the seizures themselves? Does that impact the development of autism or the severity of autism? Well, in cases of Dravet syndrome, yes, studies show that stopping the seizures early on in life, because that epilepsy is so devastating that it can impact and improve the diagnosis of autism. And perhaps when you arrest the developmental deterioration, then it doesn't go as far as becoming autistic or with an autistic characteristic. Whereas in other disorders like tuberous sclerosis complex, which is also not just genetic, but also has cortical tubers or hamartomas, then the frequency of autism doesn't really seem to change. So perhaps there's something else underlying and impacting the way the brain is connecting independent of the seizures that's giving rise to the autism. So again, knowing why the seizures are there can be very, very, very helpful in figuring out if the autism is going to happen or not. So that's why it's so important to get genetic testing. So does it matter in terms of epilepsy prevalence if you have syndromic or idiopathic? Well, we know in syndromic, because of the known gene mutations, for sure there's a high prevalence, but even in idiopathic there's a high prevalence of epilepsy. And again, they share a biological pathway for whatever reason, and genetics play a role in all of this. And just to recap again, and I don't know if you can see the top slide well or not, and so when you have a genetic mutation, whether it's a single gene or multiple genes at play, it causes a disruption in maybe the way proteins are being formed, maybe in the way that the brain is developing, and so the right cells don't go to the right places. Maybe in the way the channels are functioning, like in Dravet syndrome, there's channelopathy, or it just creates abnormal circuitry of the brain. And so either cells don't go where they're supposed to go and they get stuck somewhere, or the proteins don't do what they're supposed to do, or the ion channels don't do what they're supposed to do. And so that's what gives rise to autism and epilepsy in those gene mutations. And with the advent of microarray, we've been able to find a lot more of these genetic mutations, which has been awesome, and it's made it a lot easier. Okay, any questions so far before I go to the genetic center, or should we do questions after? Yes?
Why is it when you suspect your child has autism that your physicians don't recommend that your child takes an EEG?
That is a very good question. So it depends on who you see, right? So are you seeing a neurologist or a primary care?
Primary care is usually...
Yeah, primary care, they can't make that decision. They can't make that decision. But what you need to make sure happens is, and this is something that was established in 2000, the American Academy of Pediatrics, Genetics, and Child Neurology says anybody with autism needs to be seen by a child neurologist. Your pediatrician's not going to be able to make that call. That's not their field. And so every child with autism needs to have a neurological evaluation precisely because of all these things, because of the genetic concerns, because of all the comorbid issues, neurological comorbid issues. And so really that question is best posed to your neurologist. And depending on who you see, it could be a one-time visit and you can discuss those things, or you can have an ongoing relationship with that physician. The other issue is it's not easy to get an EEG on an autistic child, right? Oftentimes we want a long EEG because a lot of these EEG abnormalities occur in your sleep. And so you can either go to the hospital and do it inpatient, or you can go to a center like Brad Levy has, where you put the EEG on, you put it on a backpack, and you go home, or you stay there and you record it. So it's not easy. Kids like to tear it off. There's a lot of artifact. It's not a great experience, and we can't really sedate the kids because you want the EEG findings to be appropriate. So it can be difficult, but yes, you should still do it if you have a suspicion for it. Yes.
But an EEG will not. You can't diagnose. You can't say, well, based on this EEG, this child has autism.
No, I thought you meant you're autistic. Yes,
I did.
yeah, not yet. We're not there yet. They're working on getting there, but no,
Because most
not
of
yet.
the EEGs would be normal, I'm assuming.
Not necessarily. Not necessarily. There's these discharges, or there's slowing in the EEG. So it depends. Okay. So I just want to quickly review some autism and epilepsy known syndromes that we've learned more about over the last 10, 20 years. One of them is 15q duplication syndrome, and this is diagnosed with a microarray. And the deletions are in the same areas or near the areas of Angelman's or Prader-Willi's. I don't know if you guys are familiar with those syndromes, but definitely it can present mildly, it can present more severely. It's often associated with intellectual disability, and no surprise, it is highly associated with refractory seizures and epilepsy, especially with infantile spasms and Lennox-Gastaut. And over 60%, and this is an underestimate, probably more than 60% also have the autism phenotype. And again, the theory is that at the molecular genetic level, there's the GABA, which is an inhibitory neurotransmitter, and glutamate dynamic at play that's impacting the presence of seizures and then contributing to autism. Down syndrome is another one. 9% of these kids meet criteria for autism, and about 10% of them also have seizures. Again, a lot of different seizure types can present. Even early in life, you can have Down syndrome present with infantile spasms. The gene specifically is the DYRK1A mutation gene that's associated with epilepsy and autism. Phelan-McDermott syndrome, PMS, 22q3 SHANK3 gene mutation associated with autism. We definitely know there's epilepsy, but the prevalence of it hasn't really been studied yet. And these kids, super cute. I try to put some of the pictures of the kids who have these disorders on the side for you guys to look at. Seizures are variable. They can present in any way, and specifically the glutamate receptor is at play in the SHANK3 gene. Fragile X syndrome, the most common cause of inherited intellectual disability and a frequent cause of autism. And it's a trinucleotide triple repeat expansion disorder. The more abnormal repeats of these genes you have, the more severe the Fragile X. And about 90% of them have autism, and about 20% of them also have epilepsy. Tuberous sclerosis complex, it's a neurocutaneous disorder, 1 in 10,000 births, and strongly associated with epilepsy early in life. 40% up to 40% can present with infantile spasms, and about 60% of them have autism. So yes, there are kids out there with TSC that don't have autism. The P10 mutation, which is the macrocephaly gene, where you have a big head, 1 in 200,000, and associated with a lot of other genetic syndromes nearby, like Coden-Lowry syndrome, macrocephaly, autism, and also associated with seizures. The MECP2 related disorders that used to be known as the Rett syndrome related disorders, definitely know that GABA is implicated. The classic form of Rett syndrome is in females. We know that males can also be carriers, intellectual disability, and seizures, and 100% of them have autism. And the CDKL5 related disorders, these are all genes that we've isolated, you guys. Related to the MECP2 and the Rett syndrome group, 100% of them also have autism. And then the SCN1A and 2A syndromes, which are like the Dravet syndrome, and that's a channelopathy, it's a sodium channel issue. 73 to 75% have autism, present with early life seizures and epileptic encephalopathy. So autism and epilepsy definitely co-occurs. The presence of either one seems to increase the risk of another. We know that autism doesn't cause epilepsy, but perhaps seizures, epilepsy can impact the development of autism and contribute to it, and even impact the severity of it. And so diagnosis of autism in patients with epilepsy can be difficult, but it's really important to do. And the reason it's difficult is because kids with epilepsy have a lot of other developmental delays and learning issues. So sometimes it gets missed, And it's so critical to diagnose it early and start early interventions early. And both epilepsy and autism by themselves are detrimental and can wreak havoc on someone's life and their family's life, and the two together are even way more difficult. So it's critical to optimize seizure control and start early intervention. So we have to be familiar with epilepsy and autism syndromes. This is for a lot of the practitioners out there, and especially the epileptologists, they have to be familiar with autism symptoms. So hopefully in the future for epilepsy patients, they'll be referred for genetic testing right away, and they'll have a low threshold to be referred for comprehensive developmental testing, and they need to be tested for autism because there's a high correlation. And for autism patients, they all need to be seen by a neurologist. The AAP and the AEN have recommended this, and there should be a low threshold for suspecting seizures in the autism population. So those concerns about staring spells and some repetitive behaviors need to be looked at a little bit more closely and not just always written off. So an evaluation is hard. It requires a coordinated genetic, neurological, developmental testing, but early interventions is key. So just kind of rush through it. So, questions? Yes?
Do the medications, if you have a patient who has autism and epilepsy,
Yes.
and so you diagnose them as they have epilepsy, and you give them some type of Depakote medications for the epilepsy, do they help with the autism? Does it work? It does.
So that's a very good question. It depends on the medication, first of all. There are certain seizure meds that actually worsen behaviors and can worsen the autism characteristics, behavioral issues. But there are certain medications that may help autism characteristics. There's no medicine that can actually treat the core features of autism, right? But all these medicines out there treat the comorbid issues of autism. So for example, Depakote, used often for seizure control, it's also used for mood stabilization. So perhaps in the right age and the right kid, it can serve a dual purpose. There hasn't been enough research looking at the autism. So there's been research on, okay, if we give Depakote, the seizures get better. But there hasn't been research to see if we give Depakote, do the seizures and the autism get better? So that's been a little bit more challenging. Or what about the autism gets better? Is it the core symptoms, or is it the comorbid problems like the hyperactivity gets better? So that is definitely sparse in the research community. It needs to be done. More questions? You guys understood everything I said. Awesome. All right.